All right. Good morning, everyone. Good morning. My name is Dr. Panagis Skaliatsatos. I go affectionately by Dr. G, if it's a little easier, and I wanted to be the first to welcome you on a warm day here in D.C. I know it's relative as I say that because we've all been dealing with sub-freezing temperatures for about a few weeks here in the Mid-Atlantic, so the fact we're going to crack 40 degrees today, I think I saw someone in shorts earlier, so that excites me so much. You know you're from the Mid-Atlantic if 40-degree weather is like shorts weather. So I want to thank you. This is our second event here in DC from the HEAT team, our Health Education and Teaching Corps, that was started about, 2026? About 6 years ago during the COVID early years of the pandemic. Actually, we even have one of our volunteers, Patrick, who was a volunteer with us, and now he's a fourth-year medical student. So it just shows you how far we're able to impact and reach. But what the HEAT Corps mission has always been about is working with our scholastic community, working with the schools, the leaders at the schools, listening to what their health needs are, and then being able to allocate the right resources to them in real time so they can help promote health and wellness within their scholastic communities, both for the faculty, the students, and their respective families, and ideally, the neighborhoods around there. So we're bringing you our second part. We had our first kickoff in the fall. This is our second one, which is a little bit more heavier on the clinical side of medicine. And then we'll finish off in, I think June's our last one. But we're hoping to continue coming back. So we're excited you all are here. There's breakfast, there's coffee, and there's a lot of engaging speakers. And some with even better dad jokes than me. So with that in mind, that is your introduction, your warm greeting for today. And now I get to do my favorite thing, is to introduce our keynote speaker for this morning, Dr. Joseph Sakharin. And I can tell you, he has a almost 3-page biography, which I will not be reading to you. Instead, I'm going to speak for the heart. And that's a good thing to consider. If you're going to choose a keynote speaker, make sure it's someone you can speak from the heart with, right? Heart from. So Dr. Sakharin, I will give him his appropriate accolades. He has a panoply of accomplishments. He's an associate professor of surgery at the Johns Hopkins School of Medicine. He holds various administrative positions as well. He's a member of the National Academy of Medicine. With that in mind, what I want to highlight is he's one of the few people that I've come to know as a colleague and as a friend where if you call, he picks up. If you send a text message out of urgency, he's calling you back. He treats all of his colleagues as if they're his own family. His shared personal experience, he has used it to kind of amplify his public health accomplishments, his public health achievements, but more than anything, kind of a solid bedrock of public health foundation where moving forward, others don't have to have that same shared experience of his in order to kind of see the good in people, the good in community, and to promote medicine as a public trust. Dr. Sakharin, I believe, is what medicine always wants to cultivate and spring forth as a leader. I'm excited to introduce him as our keynote speaker for this morning. And my panegyric discussion of him will end now because otherwise it is going to sound like, I'm just part of his fan club, which I am. So Dr. Sakharin, please join us at the front. Thank you, sir.
All right, thanks, Dr. G. I feel like I'm so far away from you all, but they told me I got to stand here, so I'm going to do what I'm told. Can you all hear me okay? Yeah. All right, let's see if we can get this. So it's great to be here. I love, always trying to get out of Baltimore when I can and to speak to different people from across, sectors. And I know that people have a variety of different experiences as they come to kind of the table this morning. And I'm just going to share, my experience, one that, of course, is grounded and centralized in, trauma surgery, which is what I do on a daily basis. But that has come from, I think, my own lived experience and how I got here and how I then translated that into the work that I'm doing across, this intersection of medicine, public health, and public policy. And so, I can't really, I have a couple disclosures. I get compensated by Intuitive for some robotic stuff that's not related to this talk. I am the chair of the board for Brady, which is the oldest gun violence prevention organization. And, maybe like some of you, I care for injured patients. And of course, this is very personal. I can't really begin this story without telling you about these two individuals, Dr. Bob Ahmed on the left and Dr. D. Mukherjee. Because when I was 17, our lives really changed. I'm the son of immigrants. My parents came to this country in search of those hopes and dreams I think that so many of us strive for. And at the age of 17, I went from being this healthy high school senior to collateral damage after I was shot in the throat with a .38 caliber bullet. And I don't know about many of you, I think a lot of 17-year-olds, you have no idea that you're mortal. You don't really appreciate the people that you have in your life. And frankly, most of us have no idea what we want to do in our lives. And it really kind of helped me grow up pretty quickly. But these two individuals, my trauma surgeon and my vascular surgeon, along with the incredible team, gave me this second chance, a second chance to be able to really kind of be able to do the work that I'm doing today, and honestly inspired me to take this, personal tragic scenario and really, go into medicine, become a trauma surgeon, and then really think about, well, what does that mean as I continue to go down this professional path? As all of us, I'm so blessed to have people in, my life that are there through kind of the good times and the bad. As you can tell, I married up in a lot of ways. And my wife, it's funny, we met in grad school, and we have very different kind of, backgrounds that have allowed us to, come together in this work that we're doing that has navigated our personal and professional life in a way that's been wonderful, and I'm going to share some of that. I ended up training at Inova Fairfax Hospital, which is just a stone's throw away from here. And I mention this because I was born in at Inova, and then I came back there as a patient after I was shot, and then trained as a resident. And so it's hard to kind of, and this is a whole separate talk in and of itself, but it's hard to explain what it's like to train with the people that saved your life. And it was really gratifying in so many ways. After I finished residency, I ended up going to Penn, where I really started to understand systematically how do we kind of bring all this together as we think about caring for injured patients. And Philly was amazing on so many different levels, including the fact that Penn, over the last 3 decades plus, has perfected not just the delivery of high quality care to injured patients, but has also really been thoughtful about the systematic approach, the community engagement, and so forth. Now, throughout this path, I think like so many of us, the more you learn, the more you realize how much you don't know. And I had spent a year at the School of Public Health where I love this motto, protecting health, saving lives, millions at a time. And I think this reflects both the opportunity and the responsibility that we have to really think, beyond the 4 walls of the trauma bay or the operating room, to really think about what does it mean to really provide what I think is the best medical treatment for some of these patients, which is prevention. And that's because, despite how good we may think we are as surgeons, or despite how excellent, the Hopkins Trauma Center may be, if someone comes in that's shot in the head, there's very little that I could do to bring them back to baseline. And so it really got me thinking very differently about how to approach this. I ended up spending a year at the Kennedy School, which is where actually I met my wife, and really I was one of the few clinicians there trying to understand how does public policy, how does leadership, communication, all of this mix into the work that we want to do. And I'm going to bring some of this back in to this discussion at the end. And as I was going down this path, I started to realize that, all of this was great, but I still didn't understand the practical aspect of policymaking and how it could relate to someone like myself as a frontline clinician. And so I ended up getting an opportunity to spend a year as a health advisor for Senator Maggie Hassan from New Hampshire. Some of you may know that she serves on both the Health Committee and the Finance Committee. Those 2 committees are really critical because they pretty much comprise the entire aspect of healthcare legislation in America. And I happened to join her office. Again, this is for a whole separate talk, Dr. G, but I happened to join her office 2 weeks before COVID happened. And I can't even begin to tell you, like, it was wild. Like, she had this guy that was like a public health person that was a clinician that happened to be joining in her office to work on, priorities that she had. And then everything changed in a couple weeks. And that was an amazing experience. All of us in here have, mentors in our lives, and I'm so grateful for my mentors. I can't even list all of them. But one thing that I just wanted to point out, I've been talking about this concept of like reverse mentorship. I think sometimes when we think of mentors, we think of people ahead of us. And the reality is like, that's true. We can learn a lot from that lived experience. But I think we can learn a lot from the people that are coming up behind us. And I think young people have shown us that in so many different ways. But we have to be willing to kind of really listen and understand, those perspectives, and be willing to kind of not be so, I think, grounded in our thoughts that we're not willing to be malleable. There's a saying that what doesn't bend breaks, and I think that's so true. And we have to figure out that flexibility in our lives. So I'm grateful for these folks. Now, there's a lot of different things that I could have talked about, and a lot of, as a surgeon, stuff that I'm doing beyond the bedside, whether it's the work around the robotic surgery that we do, the health policy stuff, or, the work I'm doing around gun violence prevention. This is not necessarily going to be like a talk about gun violence per se, but I just want to show you how I thought about this process and how I engaged it in a kind of a multifaceted approach. And maybe some of these lessons are useful for you all as you think about things that you're passionate about, right? Because I think there's a lot of similarities and lessons that can be learned. So this is a younger picture of myself. I was in the fire department during college. Now, I know what Natalie is thinking. She's probably like, oh, look, a photo op as the building behind him burns down. But the reality is, right, perception is not always reality. And the story behind this was that this was a training exercise. So we had come out of the building as the other team went back in. And so I put this up simply to say that it is so important for us to really be able, especially in times that are so divided, to listen to each other. How many times have you been in a room and you hear someone that says something that you don't necessarily agree with? Think about what happens in that moment. Well, you stop listening to them, and the reality is that, most communication is nonverbal, so they stop listening to you, and communication breaks down, not just for that one moment, but for future interactions, because you remember that's the person that said something that you didn't necessarily jive with. And so really listening with the intent to understand, I think, is so critical. And one of the things that we have to do, especially as we're talking about super complex stuff, and that's something that, like, I've been very intentional about. Now, as I started thinking about this issue, and by the way, this didn't come kind of like naturally. This came after a lot of, I think, many years of thinking about the problem, trying to really pull this problem outside of, simply a criminal justice issue to a public health issue. I came to the realization that central to this problem, right, of violence that we're seeing related to firearms was the easy access to firearms. And if you take easy access to firearms and you add a bunch of different factors, whether it's hate, suicidal ideation, safety fears, so forth, then you could end up into a very devastating scenario. And that was, critical in really thinking about how we approach this central kind of aspect of this. And as I think about kind of the ecosystem of people working in this space, the reality is that it is not about any one individual or any one person. Like, tackling this issue requires a cross-sector, multifaceted approach. And that's why in Baltimore, we've tried to break down the silos and build the ecosystems that bring people together. It's not just about Johns Hopkins Hospital. It's about the community. It's about the educational department. It's about businesses. It's about the mayor's office. That is a very different way of thinking of how, we historically have done things, right? It's very, I think, easy to kind of sit around and talk to our friends and people that agree with us and think the way we think to try to solve a problem. But you have to ask yourself the question, is that really the most effective way? Now, in 2018, the NRA came after docs and said essentially we shouldn't have a role in this. And this is when we really chimed back and said, no, actually, we do have a role, because for anyone that doesn't think that we have a role, they clearly don't understand what we do. But also, to the point that I was just making, there is no one person or one organization that's going to solve this issue. And this led to a lot of things, including some of the stuff that we brought together through the American College of Surgeons, where the stuff that we did is not necessarily so important, but the concept of we brought together 44 medical disciplines, meaning it wasn't just the American College of Surgeons. It was emergency physicians, primary care, nursing, like the entire gamut of folks to the table to say, hey, listen, how do we talk about this in the same way? How do we not duplicate efforts? How do we work hand in hand? And this was, I think, groundbreaking, and it led to a variety of different, core groups that now function across the 44 organizations in kind of hand-in-hand effort, and that's been superb. Well, we have some of this stuff that got incorporated to Brady, which I told you I'm the chair of the board there, and you can see we have a number of different fantastic members that have helped us really think strategically about how we do some of these things to make sure that healthcare professionals have a voice in this scenario. And the stuff really, that I'm talking about nationally is important, but you can't forget what's happening in your own backyard. When Mayor Scott first started, they rolled out this comprehensive plan that he put $50 million behind. And this plan goes back to kind of what I was talking about, which is, okay, let's think about this holistically. Like, who are the people that need to be at the table? And what I'll tell you is, I think one of the most important things is understanding that community was essential. The people in the community that are closest to the problem, they understand the solutions. They don't need, someone from the Hopkins ivory tower to sweep in and tell them what to do. They need to be at the table helping define, the problems and the solutions in a way that really, I think, allows them to be true partners. And that's what we've tried to do. And as I was discussing with Natalie, there's been some tremendous, progress over these years. This past year, the homicide death is down to 133. So for those that don't know, it was historically consistently above 300, right? And that's just the homicide. We're not talking about the non-fatal injuries and so forth. Now, there's a lot of stuff that we've been doing nationally, and I'm showing you these to show you that it's not one thing, right? So we passed the Bipartisan Safer Communities Act that we really helped the Senate kind of wrap their hands around. This was a real effort, both Democratic, Republican, and what you'll notice is there's a variety of things that was included in this bill. Here's what's important is no one side ever got everything they wanted, but we were able to come to agreements that allowed us to ensure we were passing things that were going to save lives. And some of you may remember, you may say, why is this the first, federal legislation in nearly 30 years? Well, the impetus behind this one that really kind of sparked everything was Uvalde, right? And that, really, I think, it took something like that, unfortunately, to really get people to move in the right direction. Now, we know that there's a lot of stuff happening at both the state and the federal level. And what we knew, especially when President Biden came into office and actually before, as we were planning the transition, that there was not good bidirectional communication. So this was actually a paper. Now, we had worked on some of this stuff during the transition, but then we published this in JAMA talking about, what is a national approach to violence prevention? And we talked about the creation of an office, within the White House that could have technical expertise, but also bidirectional comms. And the reason that was so important is, it was a very strategic decision of where to put this. If you can imagine, every one of the agencies, whether it's HHS or DOJ or so forth, they have stuff that they're working on that they're occupied with. If you stuff this office into one of the agencies, they don't have convening power, right? Now, there's always pros and cons. What is the con of putting it in the executive, office? Well, the new administration could simply get rid of it, which is what happened, January 20th of last year. But after we had wrote this and done a lot of advocacy, President Biden created the office in 2023. It was tremendous, and they did a ton of work, over those years through the rest of the administration to really help provide the technical expertise, open up, ideas around how to engage with the states. And so, some people may say, well, isn't this kind of a waste? You had this office, now it's gone. Yeah, they did stuff during there, but now what? Well, this led states to also open up a lot of offices, and Governor Moore actually signed this in May of 2024, a statewide office in Maryland for fire and violence prevention and intervention. And, actually someone from the School of Public Health is running that office. She's amazing and does a tremendous job. So the other piece that, and I kind of mentioned this at the beginning, that we were trying to do was think about, well, people always chalk this up as like this is a criminal justice issue. And that disproportionately impacts, I think, brown and black communities. And that framing was done in a way that was absolutely, I think, detrimental in a lot of ways. And so the past decade, we have really been pushing to really frame this as a public health problem, which is what it is. And in fact, the Congresswoman here had put out, Robin Kelly had put out, year after year, an effort to try to get Congress to commission a report from the Surgeon General. We know Surgeon General reports are incredibly impactful. You think about smoking and so many other reports that have come out over the years. They really sway public opinion and help people understand, where to focus time and resources on. She could never get that, passed through Congress. But last year, before the Surgeon General left, they ended up, in 2024, they ended up putting together this advisory around fire and violence. And I think it was tremendous. And I just want to show a couple highlights that are so important. One of the things that is like incredibly sad is fire-related injuries, the leading cause of death for children and adolescents. And I think, when you think about that for a second, it's not, cancer, it's not smoking, it's not car crashes, it's fire-related injury. And I think, people really needed to understand that. I think the other piece that sometimes, folks forget is, of course, you have the person that's been injured or killed, but the impact permeates beyond that. It's these families and communities that continue to get destroyed and re-traumatized. And thinking about that impact, both, mentally, emotionally, but also from a financial perspective, if they have to care for their loved ones, is tremendous. Now, when the new administration came in, they took the report down. Now, the good news is it was written in pen, not pencil. But, nevertheless, you could tell, how politics, play a role in everything. I think one of the things that we have done as clinicians is try to also make sure our voice is heard in very different ways. And one of them is like, how we're engaging with the public. This is just one example of a piece I wrote after Charlie Kirk's assassination. And, that was a very very political time, as you can understand. And so it really had to kind of thread the needle in a right way where, I think we made it very clear that it doesn't matter what your politics are. This shouldn't happen to anyone. And I think it's really a sad kind of statement when you have people that try to justify it, regardless of what side you're on. We see this on both sides. Like, we should not see, political violence and these type of things happening. And I think if we can't say that as a community, as just human beings, we've lost some of our humanity. And being able to communicate this in a way to the public is so important. And I'll talk a little bit about why healthcare professionals, I think, have an important role in this. And other ways that we've, worked in, some people don't like to write, their own stories or don't like to be interviewed. But we've also worked with journalists to help kind of illustrate some of these issues. And this is one example we did with the Washington Post, where we really tried to illustrate, and we worked with them to help them allow the public to understand what happens when, bullets from an AR-15 hit the human body. And this was, if you haven't seen it, it's pretty dramatic. And in fact, they even interviewed parents and used pictures of kids with parents' permission from different mass shootings. And, we worked with, it was me and this other trauma surgeon from GW, actually right here. We worked with them on this. It was really rewarding and gratifying. And I didn't even, I'm like, okay, it's going to be a great piece and so forth. And ended up winning the Pulitzer Prize in 2024. So you never know how your work is going to impact, everything else that happens. And so there is value in having us at the table doing this work. The other kind of example that I want to show is we've worked a lot with the entertainment industry in recent years through Brady. I think a lot of you can probably recognize that TV and film is a huge kind of influential kind of impact on behavior as it cuts across living rooms throughout this country and the world. And so what we did is, similar to, you can think about like smoking or car crashes. What is the first thing that happens when an actor gets in a car? What do? Yeah, they put on a seatbelt. Now, do you think that's a coincidence? It's not. It's baked into scripts. So we said, well, okay, like, why are we not doing the same with firearms? Now, meaning, we're not naive. We're not trying to impede the creative ability. I am not standing up here telling you that all TV and film, they're going to get rid of, firearms. I mean, we've all seen John Wick and some of these other crazy, movies, and they use firearms in different ways. But maybe we can be intentional about how they're used. So I'll give you an example. Let's say a police officer walks into their home after a shift. Instead of them putting their firearm on the table, they can put it in a safe storage box. So imagine the message that sends. And that behavior change doesn't happen overnight. It happens long term. But again, there is no one kind of thing that we're doing. There's short, medium, and long-term solutions that are all required to allow us to kind of move this forward. So that's, just another example. Now, we've seen in Good News, and Natalie and I were talking about this, there's been a dramatic shift and decrease in gun violence across the country, and Baltimore is one of them. All of this, has led to, I think, a lot of people within the healthcare community really trying to kind of understand how do we continue to come together to, even though in Baltimore down to 133 homicides, like, is that really enough? Like, we need to continue to push that needle forward. And we came together, brought together by JAMA editor, to put together this report on what are the next kind of steps. And I think this was just published this past year and is very impactful for those that want to review it. Now, I just want to end with a couple things. When I started talking about this issue, I've always believed in like the power of narrative and like telling your story. And as a surgeon, when I started to talk to other surgeons about this, they were kind of like, okay, that's very foo-foo, and those are like soft skills, and I don't think they necessarily understood the value in it. Now, fast forward 10, plus years, I think people are starting to realize the power of public narrative. And really, when I was at the Kennedy School, one of my professors, Marshall Gans, I think really kind of drilled this in, where he talks about the story of self, the story of us, and the story of now. And I think the point is that if you want to go from value to action, it's done through emotion, meaning being able to tell your story in a way that resonates with everyday people. And that's, what we've tried to do. And some of you may have seen this Simon Sinek talk about the Golden Circle, but it's like 10 minutes. If you haven't seen it, I encourage you to watch it. But he talks about the why, the how, and the what. And the purpose here is, or the point is that if you look at really successful businesses and organizations, they don't get you because they tell you how they're doing something. They get you because they allow you to understand why they're doing whatever it is and why it's important. So they get you to believe in what they believe in. And Apple is a great example of that. So that is just such a critical part of the central equation in how we think about the work that we're doing. Now, I don't know, Dr. G, how much time we have left, but do we have enough time? Okay, so I know there's a few people in here. So I love to do this, like I do this with the medical students about like trying to really figure out the why. There's a lot of different ways to do it. But what I do is, I like to ask them, literally, the only question I ask them is, why did you, go into medicine? And they answer, and I just say why pretty much like 9 times. I don't respond to anything else. Now, that might sound a little bit corny and so forth, but what it does is it allows them to start to peel back those layers and reflect on kind of why they're doing the stuff that they're doing. Now, you can do this in different ways. One way is to ask people, like, why is it important to them? Really, like, think about why it matters. You can give them like 90 seconds to do this, and then have them turn next to each other to kind of share what they do and really talk it out with partners. So we sometimes do this in small groups like this. There's a lot of different ways to do that. I think, one of the keys is that I've always tried to think about what we're doing in a purpose-driven way. And sometimes people are so quick to kind of get to, the destination, if you will, but sometimes a journey is a destination, as they say. And that really resonates with me in the path. Like, I never thought I'd be doing the stuff I'm doing today, 20 years ago. But I got here because of the different lived experiences and the people that I came across. And honestly, the education that I've had over the years, learning, I don't mean like traditional education, but like learning from the people around me and what other people have done and other examples in different entities that have really, I think, broadened my scope and horizon. I never realized like the power of my own story when I started doing this. And this is a picture from the helipad in Philly. And I used to do this thing where I would give kids, or like 14, 15-year-old teenagers, a tour of the trauma center, and then I'd talk to them about gun violence. And the first time I did this, they're 14 years old, so they're like kind of paying attention, but not really. And I hadn't told them my story yet, and so then I tell them my story, and all of their eyeballs focus on me. And it was a reaction that I hadn't seen before, and one that I wasn't expecting. And I think what it taught me in that moment is I went from being this guy wearing a white coat to someone that these kids could relate to, and I actually asked them, how many of you have, experienced gun violence in your families, your communities, and almost all of them raised their hands. I think regardless of what you're interested in, when you think about health, there is this relationship between the community and the trust that we have to build with the community. And whether it's gun violence or climate change or immigration or racism, right? There's all these different things that are interconnected to health. We have the ability, and I think, again, the responsibility to be part of that change. I just want to leave you with what I call my 4 Ps. I live by these Ps. The first is purpose over position. This kind of goes, we all have ego. Ego is innate. If anyone tells you that they don't have ego, they're probably not being honest with you. Ego is innate to being, I think, human. The difference is some people's ego is way bigger than others. And I think, there's a lot of red shiny lights out there. You don't have to grab all of them. Thinking about, what grounds you, what is driving you to do the work that you're doing is so critical. You got to be passionate about what you're doing. I think that's like so critical. But passion alone is not enough. You got to be patient. And here's the problem. Most passionate people are not patient, and most patient people are not passionate. And so how you kind of reconcile the two is really hard sometimes. But the patience is important because all of us are going to face adversity. And you need the patience in order to be able to persevere and to transcend the adversity that we all face. This, I think, allows you to kind of carve out your own path. When I started after I finished fellowship, people were like, oh, what you're working on is a suicide, killer, like, career killer. You're going to be like, it's going to be terrible. And people also, like, the people ahead of me didn't understand, like my non-traditional kind of pathway. And it was hard for them to mentor me. So I really had to kind of, dig at it and really figure out like how I was going to navigate it. Each of you can do that, and maybe some of you are in more traditional paths, so it'll be a little bit easier. But I think really thinking about what your path is like, and it may be different than the person sitting next to you. So, Marshall says if you're in public life, you have to learn how to tell your own story. I think we all should be able to tell our own story. And so I just leave you with, what's your story? And, want to recognize, my group, of course, I'm here, but the people that are really keeping the patient at the center of what we do, they're the critical ones. And so I just want to thank you all, Dr. G, and all of you for allowing me to be here this morning, and happy to take any questions. Yeah.
So I'm going to kick it off. I love the way you ended it, because you talked about how a lot of the more seasoned professors in academic clinical medicine couldn't see how you would
Well, I mean, I think part of it was a couple things. One, it was my own kind of personal passion and kind of lived experience. But I think it was that in combination with the fact that the delta was large. I mean, when I started talking about this in 2012, it was right after Sandy Hook, and people like were not even the Democrats at the time. Not that this is I'm not trying to make this a political issue, but I'm pointing it out. Like, even Democrats at the time were like not talking about gun violence in the way that people are talking about it now. And so I realized like two things. One is that I had the ability to kind of bring my lived experience to the table, both as a survivor, but someone that takes care of patients. And I knew that there was so much work that needed to be done in order to save lives. And I felt like that work wasn't going to be sufficient after people were shot. And so, I had to think about it in the sense of like, okay, like who knows if I'll be able to make a difference, but it's worth kind of investing in because this is impacting so many people. And you only have to, I mean, it never gets easier, but like, having to explain to a mom, that her child that left that morning is never coming home again. I mean, that, reaction from any parent or loved one never kind of goes away, and it haunts you in a lot of ways, And so I felt like I was responsible to kind of, push against the grain, if you will. Yes, Natalie.
It on? Oh, okay. Thank you so much for this talk. My mind is going in lots of different directions. And as I think about this problem of gun violence, and I know we discussed earlier the issue of lead and drinking water and the environment in Baltimore City, and I noticed on that graph that Baltimore City is still on a normalized per capita level. Even though we have come down, there's still one of the highest rates of gun violence in America. And, as you think about this problem, it can go in so many different directions, right? Like, I'm even thinking about, children's early exposures to lead, leading them to not be able to sit in their chairs in school, leading them to have,
Correct.
Yeah. And so how do you even begin? When you talk about prevention, there's so many upstream channels of prevention for this issue. Where do you decide which one to go after?
Yeah, I mean, it's a really great question. So I think part of what you're getting at is like, how do you start dealing with the upstream factors, and it's very true. I mean, you think about, lead or so many other, are you all familiar with like ACEs, like the adverse childhood experiences, right? Like that, when you look at those, and the CDC published a compendium on this, I want to say like 4 or 5 years ago, it was phenomenal. Because those experiences that happen at such an early age actually impact your adulthood kind of, life in profound ways, including not just like, from a supratentorial perspective, like actually like physically, like hypertension, diabetes, and so forth. And so, figuring out how to deal with this early on and upstream is critical. To your question about, well, how do you kind of navigate it? Honestly, it's partly about, what type of partners do I have in the moment? Because like none of this stuff is done alone. And it's partly about doing some of these things in parallel, knowing that you can't achieve solutions and results on everything in a short amount of time. This goes back to what I was kind of talking about around Hollywood and the entertainment industry. When we think about this issue, Natalie, it's about what are like the low-hanging fruit, the short-term interventions, what are the medium, and what are the long-term interventions. And some of those things are happening in parallel, knowing that like culture change and behavioral change is not going to happen overnight. And so I don't have an answer to all of the different solutions, but I continue to kind of partner with people and experts to work on this in kind of a multifaceted way. And that's how I decide, how I'm going to kind of tackle it. And, now, I mean, it's interesting with the large language models and how we're thinking about the data. I mean, there's a lot of, I think, different opportunities to continue to come up, and you have to continue to adapt and be flexible and continue to learn, I think, to really be effective. Yes.
Great. Well, thank you, Dr. Sakaran. I appreciated your talk. My name is Patrick. I'm a fourth-year medical student at GW. Recognize Dr. Sarani on your slide, and also was a Heat Corps volunteer at Hopkins as an undergrad. So appreciate this talk on multiple fronts. But I think one of the things that I really resonated with is that traditional, I guess, mainstream medicine, and then I would say like the way that medical training is set up doesn't always incentivize the kind of work that you're able to do, right? In terms of just the time and the bandwidth that we have to get involved. And I'm someone that kind of came to GW and DC with these similar policy interests and curious about, I mean, you've been able to maintain this practice alongside, surgical residency and trauma surgery fellowship, et cetera. And I'm curious how you were able to manage, maybe this is kind of a me question that's less relevant to everyone else in the room, but curious as I kind of move into residency next year, how you would suggest or things that you did to maintain the connection that you've had, and whether you think that it was your personal push to maintain it, or whether you chose places that you went based on where you thought that they would support that kind of work.
Yeah, I totally get the question, and I appreciate it. And, the question actually highlights, I think, one of the biggest failures of my life, which is the fact that I was so disinvested in my personal life because I was so focused on my professional life. And I would tell you that's the example not to follow. You don't always realize it, when you're, grinding and you're just thinking like, okay, all the personal stuff will happen, when it's supposed to happen. But the reality is that you have to invest time, in anything that you really want to succeed at, whether that's professional or personal. And so I want to start by kind of underscoring that piece of a lot of this was able to be accomplished and possible because I neglected my personal life. So that's, something that hopefully you can learn from and not do. I think the other piece is that, if you're ambitious and if you want to make a difference, you're often, you saw the word I put up there, impatient. And sometimes it's like I was saying, kind of there's a lot of there's going to be a lot of opportunities in your career. Thinking about which ones you really grab are going to be important. And I will tell you that, sometimes, residency is a great example. What residency are you going to go into?
Emergency medicine.
Okay. So your goal, at the end of your residency should not necessarily, in my opinion, be that you're someone known for your public policy work, or your goal is to be a competent, excellent emergency medicine physician. And it's easy to lose sight of that because you're going to be, there's going to be an influx of all these different opportunities. It doesn't mean that you don't do some of those things. But I think, you got to be present and available and focused on what you are doing in that moment. As a medical student, your goal is to finish those 4 years as an excellent, MD physician that's learned a ton, And all of those things are kind of building blocks and components to the rest of your career. So I would say, focus on what's in front of you. Think about, you may have to try a couple different things, before you really realize where your niche is, and maybe you already know it. But then don't forget, the personal aspect of your life and the investment that needs to happen there, because that's not just going to miraculously kind of happen. And I actually, my wife and I were saying the other day, it's we actually feel like we're much more successful professionally now that our personal lives are in order, if that makes any sense. So there's this way, and I hate to use the word balance, I think it's overused. It's more, how do you integrate your work and your personal life? So hopefully you can learn, from my mistakes and I'm sure do a much better job of figuring out how to navigate that path. Thank you all so much.
All right, we're going to move right along. Hold on, let's see. Perfect. We're going to move right along into our next, and then we'll take a break before the panel. We have coming up is Dr. Marcy Johnson, a clinical psychologist and also a member of our Medicine for the Greater Good team. And, again, another introduction of a person who's near and dear to my heart. She, too, like Dr. Saccharin, will talk a little bit about, her story. And what I hope resonates is her experiences navigating kind of the patient realm and so forth. I think it's translatable. I think it's generalizable. And more importantly, it's a humane understanding of some of the challenges that we're faced as well. So with many of you, especially out in the scholastic community, there's your students are struggling, but they're still showing up. They're not conveying it, but you can sense it and so forth. So I'm hoping her story here resonates a little bit about that bigger picture and humanity that we try to put into healthcare, but something that's translatable to you all to take back into your own communities. So, Dr. Johnson, are you ready? Okay. Do you need more time? Oh, you're ready. Teasing. Come on in.
Still ready. I can't. Is there a way to do it? All right, can you guys all hear me? This feels like it's... Okay, there we go. Good morning, everyone. Thank you so much for being here. I'm Dr. Marcy Johnson. As Dr. G said, I am a clinical psychologist, and I'm also a member of the Medicine for the Greater Good team. I'm coming here today to not only talk to you from the perspective of a clinical psychologist and sort of discuss how we can take care of ourselves in the context of communicating after a cancer diagnosis, but also as having someone who has personally navigated the cancer experience and working with a cancer team. So first you had a gun violence survivor, now you have a cancer survivor. We are an uplifting group, scrappy. We're going to talk about what it's like to navigate the medical system after a cancer diagnosis. And it's going to be a pretty practical talk, but also touch on the emotional components of the experience and how to take care of oneself or someone that you know if and when they are navigating the cancer system. All right, and I'm operating two screens with two different hands, so bear with me. Okay, so I want to just start off by naming why a talk like this is even necessary. A cancer diagnosis really changes everything, and it's often the early phase that's most uncertain and can feel most overwhelming. And strong emotional responses and reactions are really common and expected. Reactions to a cancer diagnosis can include stress, feelings of uncertainty, fear, distress, anxiety, depression, and having that sense of overwhelm is really normal. And cancer is something that really affects most people. So even if you haven't been personally diagnosed with cancer or had the cancer experience yourself, if you take a moment to think of the people in your life, most likely you're going to be able to come up with one person at least who was touched by cancer. And this emotional response can exist not only for the cancer patient themselves, but also for caregivers, also for providers. It affects the whole ecosystem of cancer navigation. So today is really about helping everyone feel a little bit more oriented within this cancer care system that can be so overwhelming and confusing. Before I go on, I just want to set a few expectations. So I am not a medical doctor. I'm a psychologist, so I am not going to be giving medical advice during this talk. What this talk really is, and it's not meant to replace conversations with your care team. What this talk is aimed to do is really three things: understand how the cancer care system works, understand how to communicate more effectively with a cancer care team, and understand how to take care of yourself along the way. Importantly, you don't need to remember everything that we talk about today. This is really just meant to orient and provide sort of a framework for how to understand the cancer care system. Okay, so to understand why navigating cancer care feels so hard, I think it's first important to understand what a diagnosis actually does to a person. A cancer diagnosis doesn't just affect a person's body. It's not just a matter of abnormal cells growing in a person's body. It disrupts a person's entire sense of safety. And it creates a sense of urgency without any sort of clarity. And people are often flooded with information and decisions that they need to make pretty quickly before they've really even had time to process what's going on. And from a mental health perspective, this activates fear and uncertainty that triggers our nervous system as if we're responding to a threat. I know for me personally, being diagnosed with cancer felt like an earthquake. My world felt like it was just crumbling around me. I was having symptoms of panic. And it was really this, completely earth-shattering event. Not only was I uncertain about what the future held, but it also felt like my sense of safety and faith that things would generally work out okay was taken from me. And I like the metaphor of an earthquake because there's sort of that primary event of the actual earthquake itself, but then there are typically aftershocks that keep happening after the actual event itself. And that's really how my personal experience at least felt, that there was this sort of earth-shattering event, the walls were crumbling down, and then over the next period of days and weeks and months and years, and even today, I'm still grappling with the aftershocks of that event. Uncertainty is one of the hardest parts of a cancer diagnosis, and that's been for me personally and also something I've heard in my work for many cancer patients. As I said, uncertainty activates our nervous system, so we're actually being put into a state of fight or flight. When we're faced with a threat, our brains have evolved to respond in a certain way. So what happens is if we feel under threat, whether it's from a physical threat or something else, our nervous systems ramp up and we start having this whole biological response where our body is prepping us and our brain is prepping us to either run away, fight, or freeze. And that's actually biologically really helpful and has helped keep people alive for a really long time. And in the context of, being hunter-gatherers was great because if you run into a saber-toothed tiger, it's important that you're ready to run away or fight back or freeze so they don't hear you. Otherwise, you may be eaten. And that's not ideal for, continuing the human race. Thank you, Dr. G. However, in the context of our world today, although a cancer diagnosis is in fact a life-threatening condition potentially, having that prolonged elevation of a fear response is not always helpful and can actually be harmful to our bodies. In addition, that stress response actually changes the way that we think, and this can interfere with our abilities to communicate clearly and to navigate a cancer care system efficiently. So when we're under a lot of stress, our memory is affected, our focus is affected, and it can be really difficult to process information. And that's expected and really important to know, both as an individual who's trying to navigate the system themselves, and also as providers. It's important to recognize that when we're interacting with patients who are newly diagnosed, or even if they're not newly diagnosed, but who are navigating this complex system, they may not be processing information in the same way as they would in a different context. And that's not a weakness on the part of the patient or the individual. It's really a response that their body is having to the experience. And then on top of everything else, on top of the stress, the anxiety, the overwhelm, the cancer care system itself is really complicated. And it's made up of many people and providers and a lot of moving parts. And each role often has a specific function, and yet there's overlap between different roles. So it can be really hard for anyone in their best state to understand. But understanding the system can help reduce some of that anxiety. So I do think it's important, and I want to spend a little bit of time today talking about who's actually involved in on a cancer care team. So I won't go too deeply into any of these individual roles, but if there's any questions about them, feel free to ask. But this is sort of who typically makes up a cancer care team. So we have our medical oncologist, which is the physician who's actually treating the cancer using therapies like chemotherapy, immunotherapy, targeted therapies, hormonal therapies, and oftentimes they're the person who kind of oversees the team. They're kind of like the quarterback when it comes to cancer. We also have our surgical oncologists. These are the surgeons who specialize in cancer-related operations like tumor removals. We have our radiation oncologists, who are the physicians who treat cancer using radiation therapy. We have our radiologists, who are often behind the scenes, but sometimes you do interact with them directly. But these are the people who are reading your scans, reading the MRI, reading the PET scan, reading the imaging associated with getting a diagnosis and surveillance over time. We also have nurses and nurse navigators, and these are typically oncology nurses who are really providing the hands-on care, the education, the symptom management, and the emotional support. And often people don't think of their nurses and the nurse navigators at the forefront of their minds when they're thinking of their cancer care team. But these are the nurses and nurse navigators are often the most boots on the ground providers on the team. We also have social workers who help focus on psychosocial and practical needs. They can assist with financial needs related to cancer care and connect people with resources. They can help with insurance issues, provide counseling, help with emotional concerns, things like that. There are mental health providers, psychologists, psychiatrists, and counselors who can support the emotional well-being of patients with cancer. There's primary care, who is the physician that's the quarterback for all the other health conditions a person may be facing, right? Because cancer doesn't exist in a vacuum. You're more than just a cancer diagnosis. You may also have other health concerns, diabetes, high blood pressure, things like that, that aren't under really the purview necessarily of your medical oncologist. So your primary care physician is still the person who's going to be managing those other conditions. And then, of course, there's caregivers and families, your social support system, the people who are taking you to your appointments, the people who are helping get meals to your house, the people who are picking up kids after school. Importantly, it is okay and it is actually encouraged to ask who does what. This is a huge team, and I think it's important to remind patients that they can ask multiple times who does what. So just a slide that sort of briefly goes over who would I actually call for different situations. So for example, let's say you're newly diagnosed and there's a question you're wondering about treatment plans or test results. That would be your medical oncologist or the nurse navigator, part of the medical oncology team. Surgical questions would go to your surgeon or the surgical nurse. If you don't know who to call the nurse navigator. These are just examples. I won't, go through each one individually, but I think it can be a helpful slide to know and to share that, you don't have to remember each person. If you don't know who to call your nurse navigator. So I want to spend a little bit of time talking about why communication gets hard. Even when you know who to call, let's say you do know who to call, communication can still be challenging, and there are really good reasons for that. So as I already mentioned and we already talked about, when we're stressed, our brains are coping with a lot, and stress affects memory and decision making. So that can get in the way of effective communication. In addition, medical appointments tend to move really fast, and the information is dense and emotional. So all of those factors combined are kind of a perfect storm for communication challenges. So again, repeating this point that needing repetition or clarification is expected. In addition, I want to talk a little bit about some simple ways to make communication feel more manageable. So the good news is there are ways that we can sort of try to prevent communication issues. Communicating more effectively includes things like ways to help communicate effectively includes bringing another person to your appointments when possible, asking to record visits when you're allowed so that you can go back and review the information or review it with another person at a later time or at a time that you're less anxious or worked up. Take notes or ask for written summaries, and pause appointments when overwhelmed. Slowing things down is a coping skill. There's absolutely nothing wrong with that. In fact, interrupting your provider and saying this is moving a little quickly, could we slow it down, is helpful because they won't know otherwise that you're having that internal experience. It can also help to just have a few reliable questions you can always come back to. So, what is the goal of this treatment? What decisions need to be made now versus later? Who do I contact if I have questions? What happens next? And remembering that you can ask the same question more than once. Sometimes being prepared with sort of a little script in your back pocket can be helpful because then you're not using as much mental energy trying to formulate a question when you're in a stressful situation. You kind of have your go-to questions that you know later will provide you with some of the information that you may have missed. So just briefly, I want to talk about portals and messages and the emotional load of portals and messages. Obviously, portals are another place that communication often shows up, and often it can be sort of unexpectedly. You can get a notification through your patient portal, and perhaps you haven't even talked to your doctor. So on the one hand, right, portals have really increased access to our own medical records. We're able to see our medical records much more easily. In 2020, 2021, around that time frame, there was an act, a government act policy that went into place that required that results from medical tests immediately be released to patients. And the purpose of that act was to stop information blocking and make sure that patients have quick access to their data. However, an unintended consequence was that sometimes, like I said, results are released to patients before doctors have even reviewed them or have communicated with the patient, and that can be extremely stressful. So I know for myself, the way that I found out that I had cancer was I saw that a result popped into my portal. I wasn't too concerned about it because I was like, why, there's nothing to be concerned about here. I was on a meeting and just sort of, looked at it on my phone and saw the radiology note that I had breast cancer and hadn't talked to nobody had called me, my doctors. I don't even know if the radiologist had read it yet. Because I was the one, because of this act, it automatically was released to me, which on the one hand, it's good that I had access to those results and I had access to them very quickly. On the other hand, it was extremely stressful to see those results before communicating with a physician at all. It wasn't until that was around 11 o'clock on a Friday. It wasn't until 3 p.m. that afternoon. I mean, I started immediately trying to call my PCP, trying to call like anybody in the healthcare system that I was in to talk to. It wasn't until 3 p.m. that the radiologist himself actually called me, and because I had messaged and called, and he was like, "I'm so sorry that you saw those, like, before I had a chance to call you. Yes, you do have breast cancer." And like, it was a really stressful way to find out. So I bring up that story just to highlight that there are benefits to some of these advances in technology and communication between the health systems and patients, and also there can be unintended consequences, and it's important to let patients know that that's a possibility so that they can set boundaries around their relationship to their portals. So even now, when I have imaging results that come in, I see those results and I just don't open it until my partner is with me. I just don't do it. I've done it 1 or 2 times because I can't, like, it's stressful knowing it's in there, but I find that the stress of being alone is greater than the stress of waiting for somebody to be with me. So it's kind of picking what kind of stress you're willing to endure, and it's different for everyone. There's no right or wrong way to do this, but setting boundaries for yourself around portals, around electronic communications, can be really important. Delaying reading the results, asking for phone calls instead of getting the messages. You do have a choice in this. So I'm not going to sugarcoat it. Navigating cancer is really stressful, and that's part of the experience. Because it is so hard, it makes it that much more important to take care of yourself during the process. Stress, depression, and anxiety are prevalent and occur throughout the cancer care continuum, so all the way from prevention to survivorship. And research shows that the 12-month prevalence rate for any mental health concern or disorder is significantly higher in patients with cancer compared to people without cancer. Depression and anxiety are among the most common mental health difficulties faced by cancer patients and their caregivers. And it's really important because we know that people with depression might have worse cancer-related outcomes. So this may be related to oftentimes people who are struggling with a mental health concern. They may be less likely to follow treatment plans. They may be less likely to take preventative screens, right? So if we're even pre-diagnosis, talking about prevention, people who are experiencing a mental health concern may not be up to date with their regular care. And they may be less likely to exercise and engage in self-care, and these are all contributing factors. On the flip side of that, there's also good research that shows that patients who have gotten treatment for their symptoms of depression had longer average survival times than those patients who had more symptoms in the context of cancer. There's also work that shows that people who get treatment for mental health concerns often see improvement in their overall medical conditions and are more likely to follow through with their medical care and have a higher quality of life. So taking care of your mental health in the context of cancer is actually part of the cancer care itself. With that, getting support is part of treatment. So it's not something extra, it's essential. And there are different providers and places that people can get support from. The National Comprehensive Cancer Network recommends that every single patient with cancer and any patient-identified caregiver or trusted person, family, friend, is offered information about depression and anxiety and should be offered resources like providers' contact information and offered further evaluation and treatment when available. And with places to get treatment, it might be with an oncology social worker, a mental health professional, support groups, faith or community leaders, or through your primary care physician. So a couple key takeaways. Feeling overwhelmed in the context of a cancer diagnosis is normal and doesn't mean that something is wrong. As a psychologist, I'd actually probably be more concerned about somebody who was diagnosed with cancer and was like, all good, no worries, than somebody who's freaking out about it. It's a very normal response. A cancer diagnosis affects the body and the mind. And coping with uncertainty is really tricky. The brain hates uncertainty, and it can send us into this state of anxiety. Understanding the cancer care system can help reduce that anxiety, and caring for your mental health is part of the cancer care, So just a few things to remember, whether for yourself or for someone you know who may be dealing with a cancer diagnosis. Some takeaways just to keep in the back of your mind. Slowing things down is a coping skill. You can ask the same question more than once. needing clarification is expected, and you're not alone on this journey. There's a group in Annapolis, Maryland, who is actually running a pilot program for newly diagnosed cancer patients. It's completely free of charge, and they assign a member navigator to help coordinate care and community resources. So that's through the Wellness House of Annapolis, and I just wanted to sort of spotlight their program because it's a really great resource for anyone living in the Maryland area. Here are just a couple other resources that I'm happy to send along with this presentation. And I'd love any questions from you all. Thank you.
All right, well, I'm going to ask the first question, Dr. Johnson. Thank you for that presentation. You did mention you are a clinician, a psychologist. Do you feel like being a clinician and then being a patient, there's anything that helps, that side of the world, being a patient, knowing the clinical arena to some extent, even if it's from mental health? Does it help at all? Or honestly, being a patient is its own beast?
Both. So I think that one thing I just want to name is that even clinicians freak out, right? Even though you may know sort of from your training and a clinical perspective how to effectively communicate or what are the next steps in terms of taking care of your well-being. When you're a patient, right, again, you can be in that fight or flight position. So I think both. I think having a medical background and a psychological background, of course, right, that's going to be helpful in maybe knowing what types of questions to ask, and also being a patient is a completely different experience. And so I think both of those things.
What's one thing you hope family members of people who've been diagnosed with cancer take from this?
I think it's important to remember that a cancer diagnosis doesn't just affect the patient with cancer. It really does affect the whole family system and community system. And so knowing that taking care of your own mental health as a caregiver is critically important to the patient as well. If you're run down, if you're not taking care of yourself, you are not going to be as effective of a caregiver for your loved one. And so I think oftentimes, right, caregivers might think like, well, I'm not the one who's going through the cancer. Like, I am just going to spread myself as thin as possible so this person doesn't have to do anything and I can take care of them. You need to take care of yourself also. All right. Well, thank you all.
We have a great group of individuals. I'm going to actually start off with Molly to introduce herself, quick one-liner, and then we'll go down. We'll finish with Jack, and then turn it over to me, and then we'll start off with our questions. I know we're standing between you and lunch, so hopefully you had a big enough breakfast where it's carrying you through. But all of our speakers have been amazing so far. This should put it over the top. All right, Molly, go ahead. A little bit of an introduction.
Hello, my name is Molly Young. I'm a child life specialist and public health researcher. I've been at Hopkins for about 15 years and have trauma-informed care subject matter expertise. I sit on the mayor's task force for trauma-informed care in Baltimore City. So really excited to talk about this with you all, and yeah, excited for the conversation.
Hi, everyone. I'm the same person who was just over there, just moved locations. I'm Dr. Marcy Johnson. I'm a clinical psychologist, and I'm very happy to be here as well.
Good morning. My name is Thomas Cujo. I'm an associate professor of medicine. Specifically, I do geriatric medicine, do house calls, and then focus my research on the social connections of older adults. So great to be with you all.
Hi, I'm Jack Iwashina. I'm an intensive care unit doc. If you're lucky, you don't know what the difference between an intensive care unit doc and an ER doc is. May your life stay that way. And I am, I think most relevant to this, married to a longtime teacher.
Oh, excellent. Well, thank you. I thought it sounded like someone was about to give you some applause for that, so fantastic.
I mean, you've met my wife.
I know.
The fact that she has married me is far and away my most impressive credential.
I feel like we've all married up in this room, so this is good. Because our keynote speaker talked about that a lot this morning. So with that in mind, let's dive in. And actually, I want to, because I know this is, the community here is a lot of it is based around the scholastic community of DC, the Mid-Atlantic, but I want to actually start with our geriatrician. And Dr. Cujo, one of the reasons I wanted you on this board is because of the social isolation epidemic that we've seen grow and rise here in the United States. The former U.S. Surgeon General put out a plea. It is a public health crisis. And so as you as a geriatrician, how do you think the school systems could be leveraged to help this aging population that has so much to still give back?
Yeah, I appreciate you offering up the question, because I was beginning to try to think through intersections with school-based things, and so one of the things that my mind readily goes to is, so I guess it was probably in the late 80s, 90s, 2000s in Baltimore. There was I would say one of my predecessors and leaders in my division, Linda Freed. She was the chair of our division and then went on to become the dean of the Columbia School of Public Health. And one of the things that she did in her career while in Baltimore was establish and develop this initiative or intervention called the Experience Corps. And so Experience Corps essentially is a effort whereby older adults go into schools and work on reading and literacy with young people. And so we think about that as an intergenerational connection opportunity, but also an opportunity to help bring up literacy scores amongst the young people, but also an important source of cognitive stimulation for people as they age, and then also, I would say, a means to combat isolation in the older adult population. And I think also, some of the benefits that I think are associated with that is bridging connections and community, whereby people see that there's a role for the engagement of two different generations and understanding and learning and the value of each group. I think so often we potentially can be siloed in our generation. When you're young, you're mostly focused and spending time with younger people. When you're in midlife, right, if you're spending a lot of time raising a family or caring for older people. And so I think creating opportunities where younger people and older people can come together in meaningful ways is really, really important. So.
And just one more follow-up to that, and the ability kind of, because the older generation also has the ability to kind of share the socio-historical context, right? The youth, they're just viewing the city in their moment in time where the older generations had, decades. Mm-hmm. Is there value in that concept? And that's not just coming in, helping out with school engagements, but being able to kind of discuss the history. Because many of us, especially when they're younger, this is it. That's all they know. And they may not be fully aware of the Baltimore of the past or the DC of the past and so forth. How does that kind of a history lesson help?
That also resonates with me, and I think it's also, thinking about narratives and experiences and how we transmit that across generations. I think there's a value and role for that as well. So.
Yeah, I appreciate it, Dr. Cujo. Molly, I'm going to pivot to you next. So let me start off with a quick question. Where's your biggest touch point with your patient population in pediatrics? Where do you come across them most often in the hospital? In outpatient, inpatient, where do you?
Inpatient.
Inpatient,
But
where?
really both.
Okay.
At the bedside, my prior clinical experience was in radiology, so that was everywhere, inpatient, outpatient.
And with that insight, what is some key differences between meeting them at the bedside, inpatient versus outpatient, that you'd like to share with the community here a little bit?
I think outpatient appointments you have less time, so your assessments are important. I think especially when you're applying a trauma lens, an outpatient setting is the perfect place to just think about that universal approach. Because you have such little time, building rapport quickly can be a challenge, but is really important to build trust, to achieve your outcomes of what you hope the patient to accomplish in their appointment. Inpatient, you have a little bit more time to get to know them and build rapport at the bedside at times that seem to be better for them. You can ask and give choices. Could I come back in a little while? Like those kinds of questions can help people feel a new sense of control or a new sense of control, or even build trust through those questions. It gives people kind of that agency over their time in the hospital. So I think thinking about it through that lens of, regardless of the setting, kind of meeting them where they are and adapting your approach to match that.
So continuing with that, I'm pulling this into kind of a direction. Are people surprised when you show up to have these conversations? Was this something they were expecting? Because I feel like when we think of healthcare, right, and going into a hospital and so forth, and now potentially massively confounded by the pit and what people are expecting. When you show up, how are you received, and what are you most surprised about that the patients are willing to discuss and engage with you?
Yeah, so I think a lot of people don't even know what a child life specialist is. So I think just sort of introducing my role sometimes and parents hearing and patients hearing that what I'm there for can be just a supportive presence can be helpful. Something that I was kind of thinking about when you were talking is how helpful I feel like that role, like the psychosocial support, can be in the outpatient setting when navigating if you have just received a cancer diagnosis as a pediatric patient, and now you need to do all of these things for treatment. You have to, a 5-year-old might need to hold still for 45 minutes. All of these things that sound really overwhelming and are really overwhelming can really be presented in a way that's so much more doable and really feels like a partnership with families. So I think in many ways, families are happy to see me and happy to have that extra support.
So I'm going to now pivot to my colleague Jack here, who, he's probably maybe like me, because I'm an intensivist for adult patients, and I'm like, I wish we had an adult life specialist come and talk to us. And Jack, tell us about the ICU from that standpoint when treating adult patients. As intensivists, what gap do you think we have that fails our patients who are in there? They're going through their own traumas. And while we try to bespoke plans in real time, oftentimes, and I say this with a lot of love, but I still feel like we fail. Like, what do you think we could be doing more to the adults who come and see us in intensive care units?
That is a great, hard question, in part because there aren't enough of us, right? So if we're going to talk to the school community here, and they're going to look at us and go like, wait, tell us what it's like to have more than 2 people taking care of 25 kids at one time, let alone the idea of being able to do this one-on-one services. I think one of the challenges, and again, as I was talking with my wife about this, that some notions of trauma-informed care came to the notion that like the person you're dealing with had been traumatized, and now you're trying to help them through whatever's going on. Where it's like, I am the trauma, right? Like, if I'm meeting you and you're not in a bed, I am telling you that one of the most important people in your life has a really good chance of dying tonight, and here's how we're going to try to walk that through the middle. And so I think thinking about how we avoid causing more trauma, how we can meet people where they are with the incredibly long histories that they have, and how we can give them enough space. But one of the places I'm always envious of my colleagues who work in the outpatient setting is that bit where you get to go like, we can come back tomorrow. And as you and I know, often we've got to make a decision in the next 10 minutes, and if we could pull it off in the next 5, that would probably be better for everyone. So how you scaffold people around that. It involves making hard choices. I think one of the central questions is how do we help our patients and their loved ones as there is ongoing trauma in their life, prioritize and figure out how much they can take on, how much of that agency that they can carry, and how much they need somebody else to carry right now. And not asking them to do either more of that or less of that is right for them at that moment. And then 6 hours later, figuring out where they are there.
Yeah. No, I appreciate it. And, I'm going to finish with Dr. Johnson, with Marcy. And the reason I'm setting this up at this moment is just from a healthcare standpoint, right? Because one of the challenges I think we have where the community views us is it's a healthcare system. They have all the right resources. They're good to go for trauma-informed care. When in reality, when I'm hoping comes all across in a few minutes, is we need everyone, all hands on deck, from schools to hospitals, because this will transcend those walls. Appreciate it, Jack. Marcy, when you see patients, right, as a clinician, as a mental health specialist, how do you begin these conversations around trauma, around what they've been through? Because I imagine even with the best physicians, it's a sensitive topic to bring up, but it's important because it complements the management of a patient. So from your standpoint, how do you begin these conversations to unlock their ability to trust and discuss?
Yeah, that's a great question. So a couple of things. First, I think one of the great strengths of a trauma-informed care approach is that the person doesn't actually need to disclose the trauma that they've been through. We don't actually need to know what's happened. We're coming into the room, it's a shift in perspective from, what is wrong with this person to what happened to this person. So this general idea that all of us have experienced tough times in our lives, whether it's a little t trauma, a big T trauma, and all of those collective experiences make up who we are. We're more than just whatever diagnosis we have or whatever acute experience has happened to us. So I think that's a real benefit and why trauma-informed care is so effective across all these different disciplines, because you actually don't need to know what happened to the person. It's an approach that you're taking as the provider. As a mental health specialist or a clinical psychologist, when I'm working with patients one-on-one in an outpatient setting, it's a process of building trust and rapport. I'm not gonna jump right in when somebody comes into my office and say, so tell me about the hardest thing you've experienced in your whole life. You don't know me, we're pretty much strangers, but let's hear it. I'm gonna follow their lead. If they come in and they need to get it off their chest and they wanna jump right in, I'm there, I'm non-judgmental, I can be present in the room with them in a way that maybe they hadn't had an opportunity to do that with somebody else in the past. But it's really a matter of following their lead, building trust, building rapport, and knowing that, even if they're not disclosing the trauma immediately or in the even first couple weeks or months that we're working together, everything that we're talking about contributes to who they are as a person. And so that's really valuable in the therapeutic relationship and also just in their progress.
Noted. By the way, if there are questions, you guys from the audience, raise your hand. I'm happy to call on you. I thought I heard. I didn't want to interrupt anyway. So if you have questions, just put your hand up. We'll grab you the microphone.
Can I ask it?
Yes.
Would you mind defining trauma-informed as we meet it in this sense?
Molly, would you like to dive in?
Sure.
Yeah, go ahead.
Sure. My personal, definition and philosophy is that trauma-informed care is universal. It can be applied in any interaction with any person clinically, with your family, with your friends. It's really a mindset shift, and I follow the 4 R's, the sort of the SAMHSA framework: realize, recognize, respond, and resist. So it's all about realizing that the trauma has occurred, recognizing what sort of trauma responses or symptoms we might be seeing, and also kind of giving myself having kind of an ongoing dialogue of just raising the possibility of trauma. Even if we don't know that has been this person's experience, just raising it as a possibility, especially if there are any behaviors that might be signaling to me that there's more going on. And always doing that without judgment, completely eliminating judgment from that as much as possible, which also might mean taking a step back and sort of challenging your own sort of unconscious biases and your own experiences and your own identity. So I think it's kind of a really big around the world definition, but
and it's a great question. That way we're all on the same playing field, but I want to make sure the panelists have the opportunity to also weigh in. Dr. Johnson, or Marcy, did you want to add more to that, or?
No, I agree. Ditto.
Yeah. Well, keeping with these conversations, because now we're going to start bridging out to the community realm. Thomas, back to you. I know, again, our geriatrician friend, but what I love about your profession is it's not so much also focusing on, the way most internal medicine doctors do, like disease specific. You're very big on the quality of life. A lot of the aging population still is, for some families, maybe the primary caregivers for the young, right? The grandparents who are full-time taking care. How do you prepare them who may come to you and saying they're struggling? Like, how do you prepare the aging population to help respond with our youth who are going through a lot, especially in a time that may look different for them, right? Like, I remember my mom had no idea what social media was. And so when my 7-year-old is telling her about YouTube Kids, she had no clue, right? So she was she's calling me. She's like, your daughter's viewing something. I'm like, well, I'll walk you through this. How do you prepare the aging population to help?
Yeah, so I think, in all these things, meeting people where they are, and one of I literally do this in the clinical work that I do, meeting people in their homes. And so I think also...
Can you tell them another sentence about that? Because it took me like 3 times to hear that, like, how cool your clinical practice is.
I don't know if it's that cool, but
take a second.
No. So we have a pretty well established home-based primary care program where we go and deliver primary care to people who can't make it into our clinics. And so since the 70s, our group has been doing that. And so in terms of going back into, so literally we meet people where they are. And so I think to the concept and idea that you're bringing up about how do you help prepare people to navigate circumstances that they may have not foreseen themselves in is taking stock of meeting people where they are, understanding that people have had different experiences that may have been traumatic or not. People have different resources that they can pull on, intellectual resources, financial resources, like physical resource to support people in their needs. So older people supporting younger and vice versa. And so I think we have to continually remind ourselves, even as providers coming in or clinicians coming into those situations, that we have to assess and meet people where they are and then help where there's supports or mutual aid or needs being met. within one's own family, you know, that they have to meet each other where they are. And so that's kind of the thing that I keep in my mind, and being patient, because, you know, Rome wasn't built in a day, right? You know, so the things in advancing and moving for whatever challenge that exists in the families, and then also in our relationships as clinicians, we can't, you know, it doesn't just happen, you know, overnight or in moments, and so it takes time. And so reminding myself of that, reminding of the people who I'm working with of those two things, meeting people where they are, and it takes time for these things to move forward. So.
Yeah, no, and I appreciate it because, again, from the school community standpoint, right, if they were reaching out to families, you know, to discuss what's happening in the schools or with their kids, you know, I imagine, you know, just like myself, I do some outpatient time, your patients bring you that conversations. And so how do you help them navigate that world and so forth is going to be important. You do, as Jack mentioned, Thomas, you do have the advantage of meeting people literally where they're at, going into their home. So I think, you know, we're all a little jealous of you from that standpoint. But it helps, right? It helps you have an understanding of what's happening in the home, how you can better service them. And for the school community, too, recognizing if there are clinicians like that, or just overall, the doctors and so forth, and how they can play a role between the schools and the healthcare system, it'll be important.
Yeah, and I even know, like, I was on the school board for East Baltimore Community Schools, so Henderson, Hopkins, and I know one of the things that the principal there, Principal Canham, did in his, I'm assuming they may still do some of this, is one of their big things was trying to get students to show up on time to school. And so one of the things that they would do as a school is they would go to the homes. And so I do think, you know, trying to be proximal to people in their context and trying to understand, you garner a lot by, you know, meeting people where they are, going to homes. And so I know, I'm saying this example that so schools are doing this as well, and there's all types of other campaigns beyond schools in our health system that understand the value of going to people's homes and trying to support them and understanding them where they are. So.
Yeah, no, because, you know, those aspects from the school, you know, child's not showing up on time, you know, the homework wasn't done. I mean, those could be surrogates towards a much more complex conversation. So we see this as physicians if we can go there, right? We look for certain clues and diagnostic insights and saying, well, maybe something's a little bit more concerning here. Having them come to our clinic too, we look for similar clues, but, you know, it's all about, you know, what does this represent, and is it a piece of a bigger issue? Jack, I want to ask you, and then we're going to finally dive a little bit more into the outpatient world, but the body survived, right? The patient has survived. Physiologically, they'll be okay. What do you think a hospital does and can do better to really prepare them, though, for the mental health ramifications, right? Because especially surviving in ICU, that experience isn't leaving you. What do you do as a clinician? What does the health system do, and what can it do better? And that poker face of yours says...
how many seconds do you want me to do this? I mean...
Lunch is, you know...
You know, so it'd be, like, there's some basic stuff, right?
Yeah.
Like, it'd be super great if we didn't bankrupt them. It'd be super cool if, like, we made sure they were discharged to, like, a house that was, like, a house, and that they could get, like, the medications and the follow-up stuff. Some health systems that tend to be a little more focused on what they call tertiary and quaternary care are not always so super good at some of that stuff. So I think there is a foundational component, and the extent to which I can spend $1 million a day in outlandish testing, treatment, and research the minute you're in the ICU, but that our School of Nursing developed something called the Capable Project that found out there's this intervention that if you send basically an occupational therapist, a social worker, and a carpenter with a $500 budget, like it was something that, like, for healthcare dollars, just it seems like that's nothing. I wasted that in labs this morning. Dramatically reduced readmissions, right? Again, sort of helping people where they are, as opposed to trying to say, what can I jam into you from my sort of narrow lens? I think pragmatically, the single most important thing we have to remember is that we're taking care of a family but we're usually only treating one body. And we've got somebody else who's got a chair like one of these that they've been sleeping in for the last 7-8 days, and we're going to send somebody home to take care of that. And they're going to be a mess. So I would say one of the things where we've primarily been trying to learn from child life in a lot of ways, who has always been pretty intentional about the idea that you can't take care of a kid without taking care of their parents, is you can't take care of an adult without taking care of some of their loved ones, and at least trying to avoid making it worse, even if I can't make it better.
So, and one of the reasons I wanted to have the ICU represented here is, and you hit it, right? Even in a shorter time than you were expecting. But the social challenges that the loved one faces in the real world will exist when they go back out. And I say this because the schools probably face the same thing, right? If there's a housing instability, it impacts our patients, but it impacts our students. If there's food insecurities, right? If we didn't take that insight while they're in the ICU and we're just going to send them back out where they're really challenged with accessing good nutritional food for their health conditions, they're coming right back, right? And so these concepts impact your students, but impact our patients. And the reason why we have Jack here representing the ICU is because those social factors can become life or death.
Can I suggest one other thing where the ICU may be of some use? Is that in the ICU, we always admit that what we're doing is team care, whereas in the outpatient setting, there's still sort of this sometimes mental model about one provider at a time, as if it's sort of like old-timey family practice outside of a shingle. And so I think one of the things in the ICU we are getting increasingly intentional about is trauma-informed care provision, right? So there's an old book called The Wounded Healer that I'm sure you've read. Dealing with the fact that like our nurses 5 years ago used to have their ID badges with their last names on it. And I can't think of the last time I saw a nurse's last name, because they all put stickers on them because they are actively concerned for their safety, and and being harassed on social media by patients' families for saying things like, "You have COVID." And so that when we, care in a 2026 ICU, and I think in a lot of ways, like care in a 2026 school, also means meeting your colleagues where they are, and how you can think about what you can ask of a colleague today and what they're just not going to be able to give, even though we all know that you want to be able to give it. But to be able to bridge around that as a team to make sure you can collectively do the things whenever somebody's not necessarily having a good day, because I think for both of our noble professions, it's been a long 5 years.
Well, for me, the ICU is the canary in the coal mine, right? It's the first one to and it's a life or death coal mine too, right? And it's one to kind of really signal how well or how bad things are going along. Oh, were there questions? Fantastic. Oh, so sorry. Thank you, Megan. Yes. But good points, Jack. Thank you.
Test.
Perfect.
Hello, everyone. My name is Antonio Wilson, and I work in DCPS school admin, elementary school to be exact. And I have a two-part question. But my question is, what is the best what is the best practices for managing asthma and other chronic respiratory conditions in students during the school hours? And how can we improve the air quality and reduce respiratory issues within the school environment?
Excellent. Dr. Johnson, as a clinical psychologist.
I'm going to turn it over to you as the asthma expert.
Fantastic. Yes, sir. You're moderator, by the way. I don't know if I really ever introduced myself, so I apologize. So I'm Panagis Galiatsatos. I go by Dr. G, but I'm a lung and critical care doctor. And so, yes, asthma, air quality is like what I live and breathe, no pun intended. So I'm going to, if that's all right with the panel, I'll take this question. But it might not be a full, complete answer, because I'm going to give some generalizations. First of all, I was hoping that the COVID crisis would put more attention to the air quality indoor, right? Because we focus so much on like being 6 feet apart, wearing masks, so forth. To me, I was like, oh, this is it. This is like the inflection point. We're going to put better standards for better HVAC systems into the schools, because we're concerned about like how the bugs are. This is it, right? We had Dr. Exum was here earlier. She's our water expert, and she can talk about the public health inflection point for good, clean water was over a century ago. And then nothing happened. And then yesterday also with the EPA rollbacks.
It got worse.
I know. So with that in mind, I'm going to give some answers, what the school can do, and then like what we should be doing. Because air quality to me is so important, right? If the kids can't breathe, they can't learn, they end up in our ICU, Molly's meeting them, like that's, again, not great. A couple things. One, and I apologize for this basic one. One is to see if the curriculums can introduce a little bit of insight about what air quality means, right? What asthma means and so forth. And I know this is a bias as a lung doctor, but I do think with the appropriate pedagogy, having the kids learn about it creates a little bit of advocacy from their standpoint. We've done that in Baltimore. We have gone out, we've created a lot of curriculum focused on air quality, climate. Where we're at in Brooklyn, Maryland, you can see a variety of old factories. These kids create an advocacy where they go out and begin to kind of have these conversations. And I see this because if the kids can get motivated outside of their colleague who has asthma, then suddenly you have a collective, cohesive force of an invested student body where they're seeing things in real time being impacted. 2, then start focusing on things that the students can do outside of the school, right? So meaning, some of our curriculums, we focus on how do you build an air filter, right? An air quality filter. And it's easy, right? It's you use you buy an air filter with a MERV setting of like 12 to 15, you put it on a box fan, and you just teach the science behind that. And a lot of our rooms that we go out into the schools, Marie G. Faring and Armistead, I know this is Baltimore-centric, I apologize. You walk into the rooms, they have those boxed fans with an air filter on top of it, purifying the air, right? Simple things, right? But using the science to kind of motivate the kids beyond that. 3rd, I love that schools have nurses on hand. Those are great, don't get me wrong. They will help with asthma symptoms, but they are costly, and I don't know how easy that is.
Not easy at all.
Perfect.
Department of Health took over.
Good. So what we have done with the same thing in Baltimore is we've grabbed teachers and converted them also to community health workers. Training with a little bit of medical insight, but what their job is how to get resources for the kids for asthma, how to get the inhalers, how to get the spacers for the inhalers, how to help their parents set up doctor appointments, right? How to navigate the ED system, right? We have a large immigrant population where these teachers are focused at. So a lot of the immigrant families have no idea how to navigate an American pharmacy or an American health system. 1.5 years of doing it, attendance rates have improved at Marie G. Faring by 40% and at Armistead over 60%. Actually, their principal is like we have a 94% attendance rate solely by having this amazing community broker, a teacher who became a community health worker, doing both roles, paid as well. We don't want to overwork people. But that, to me, is important because that person understands the community resources they have. So a 3-prong approach, I'm not saying it is the key answer, but a curriculum that motivates the students, hands-on activities that they can build and transfer it back to the house, right? And then can you find the right liaison in that school who is motivated enough and with the right compensation can take over with a lot of the chronic conditions that these students face? Does that make sense? Or just vote the right politicians in to change the school systems and improve the HVACs, right? So, but outside of that, that's my immediate response.
Thank you.
Yeah, no, great question. Keep them coming, by the way. This is typical pulmonologist.
Here's a second one.
You have a second question?
Yeah.
Go for it. Yes.
Okay. My second question is, how can I incorporate understanding of aging and geriatrics into the health and curriculum of the school? Like, how can I promote like intergenerational wellness?
Excellent.
Basically.
Excellent. Marcy.
Yeah, Marcy.
I'm teasing Thomas.
I think you're the expert on
Yeah,
this.
I mean, I think I haven't thought about this
Well,
much.
so I'm going to give you a little context.
Okay.
So for for the children that we serve, my elementary school children, 0 to 5th grade, We have programs like UPO Grandmothers, where we have elderly individuals or grandfathers come into the school and they are assigned a classroom. So our children resonate with the elderly. But once they're out of the kinder classroom, I can't, so I'm trying to bridge the gap.
Yeah, no, so I think what you're describing is very similar to the initiative that I described earlier about experience course, so having older adults come. And so what I'm hearing you say is, how do you continue these types of engagements beyond those early years? And so I do think, strategies to continue to bring those groups in, and then also beyond. I mean, I think in the schools, having older teachers who've retired to somehow be mentors for younger teachers and present for the students as possible. I know after many years of teaching, I'm sure people like Jack's wife, who when they're ready to retire, they're like, no, I don't want to see the school anymore. But I do think there's a role for continuing to have some of these individuals around. I think in our academic settings, these are like these emeritus faculty somehow still, are present in our context and mentoring and contributing. And so I do think that schools and beyond can leverage some of these approaches to bring people who are more senior and who have experience in those settings around. I think also beyond the schools, and it may apply for some schools that double as community centers, is thinking about how do you have intergenerational programming in those spaces. I know we segregate senior centers and youth centers, and so thinking about ways to have those spaces that are common could be a strategy where capital improvements can be made to bring a center that has both programming for older people and younger people. I think the why is to do this well if we're expanding beyond schools, but I'm going on a tangent. So, but that's what I would say.
Thank you. Hey, man, you just gave me an idea. I think I might open up a daycare for the elderly and the children.
Yes.
Oh, I love it.
Could I add something to that?
Yes.
Just my personal experience. My mom she taught public school, special ed for 42 years, and she moved in with me recently. She's almost 80. And something that's been really amazing to see is she's been volunteering with kids on the block and doing after school tutoring and just sort of on the porch, not nothing formal. But I think if you already have a pool of older adults who had been volunteering with the younger kids, maybe tapping into that pool for even when asking older adults I love to talk to people older than me and hear about their life experiences. And as a kid, I loved it even more. So even storytelling, I think, can be so powerful for kids to hear from older generations, even if it's just to come for story hour, as simple as that might be, but also I think tutoring after school, especially if they have some kind of background like we were talking in schools and with kids. My mom wants to help. So I think, most people, especially now, it just feels like there's such a need and so many kids benefit from having that one-on-one support. So I think something like that, tapping into it sounds like you have a rich resource pool of people. So kind of pulling strengths out of that.
I'll also add one thing
If
we're not over this question yet. No, but I just want to double click on something that Dr. G said that's kind of in line with both of these things. I think it can be so effective to identify community brokers and community liaisons and people within the community, sort of what Molly was saying, who are wanting and willing to do some of these things, whether or not there's financial compensation or it's a volunteerism or whatnot, right? Those are logistics that are, downstream. But the community is the expert on the community, as you are well aware. And so identifying community brokers to help implement, all of these great ideas, I feel like is just worth saying again.
And what I would continue adding to that is and this is where collaborations with your local healthcare system can help, because oftentimes the community is the closest to the solution, but they're the furthest from the resources, right? And how to allocate them to you guys and how to get them to you all makes the most sense. Because as you heard from here, right, especially our inpatient providers, we do some, but I mean, we are not as organized as you may think, right? If the pit's giving you an impression like healthcare systems got it down, we don't. And so we do rely a lot on the community and then the resources you have there as well. But I do think having a bidirectional relationship with an academic institution or healthcare system to allocate those resources in real time makes the most sense. We're probably going to do another 5 minutes. We'll bleed a little bit into lunch. Is that okay? Are you guys okay? Because I think we're having fun, but maybe it's just my personal bias. You asked a lung doctor a lung question, so now I'm like, we're ready to go. Friday has kicked in officially. Any other questions before I ask a few more to the panel? Is that
I have one more.
One more. All right, go for it. Go for it.
Anybody else?
No.
Sorry, guys.
This is making him so happy that someone else is asking questions.
There is an email question, so obviously someone is streaming. So I'll get to that after you.
All right, this is the last one. Okay. How can schools ensure proper medication management and compliance? Now, I know we talked about the nurses. And are there any new guidelines or particularly relevant to what did I say? Particularly relevant to school-age children, like vaccinations or anything, because COVID, just help, please.
All right, Marcy.
I can give you a hug while Bungie's talking.
No, that's my role. I'm the emotion person. You're the MD.
So I'll start off, and then whoever,
We all start.
and then whoever just jump in. This is from my standpoint why schools having some relationship with a healthcare system makes so much sense now in the 21st century. In Baltimore, in the fall of 2025, so a few months ago, with our CHW teachers that we had, they started emailing me and calling me about they're having an outbreak with hand, foot, and mouth. So go ahead. What did you used to do in the past? I'm like, I'm happy to provide resources. What did you guys used to do in the past? They're like, oh, we would report it to the CDC, but no one has responded to us of how to respond. So now we're looking, can you help? And so politics aside or not, they do dictate health. And, we kind of have a good sense of recognizing we want our students in there, ready to learn and so forth. Preventative medicine, like from vaccines to medication management, has always been part of that, right? My mother wore her smallpox scar from the vaccine proudly, because she saw it eradicated from her village after the vaccines came in. So what I would my first big suggestion, wherever your school is, what is that local hospital, right? Is it Sibley? Is it George Washington? Is it Georgetown? Touch base with them. Is it hospital center? And just say, can we just have an open dialogue and relationship? That way, if we have any challenges, we can look to you guys for potentially some guidance. Even if it's not something that impacts your bottom line, right? Because healthcare systems may think like that. Are we preventing a hospitalization? Oftentimes it's not, right? There could be the hand, foot, and mouth outbreaks. They didn't land in the emergency room, but they kept kids out of the schools. So I would say start there first. Build those relationships. So regardless of the cacophony, the noise that is happening, right? In the federal system, and it's crushing. It hurts. But if you can have that strong relationship with your partners in the neighborhood, I think that's where I would suggest to start with. Jack, and then keep going down.
Slightly more candid than you just were.
His microphone's still on. Perfect, yes.
All right, so I am speaking as an individual. They don't let me run anything for really good reasons, so I am not speaking on behalf of any institution. For the last 50 years, one of the relatively easy thing as a teacher has been that we've had superb recommendations that have largely been the gold standard in medicine for what the science says y'all need to know about vaccines and turnover and how long kids should stay home. Those have been intentionally and actively destroyed over the last year. And so the current federal resources are not reliable and in many cases are simply wrong. We are having a measles outbreak in Baltimore in 2026. I had to look up mumps the other day because we are having a mumps outbreak in Baltimore in 2026, right? Like this is, and so I think it's going to be really important to build local partnerships and to, on a county and state-by-state basis, figure out whether your county or state is still providing reasonable guidance or you need to route around those to get somebody who's keeping up with the best evidence through the responsible professional organizations, not the irresponsible ones, which have also been created. Y'all have enough to do just figuring out what the current best practices around phonics and literacy. You do not need to be reading sort of the latest data studies about guidelines. And so I would say I have not met a pediatrician who is not basically apoplectic about this. And so it's actually pretty easy, I think, for a couple of years to find somebody who's responsible at a local academic center where they can call this part of their job and it's community outreach to be with you. But I think you have to, on a school-by-school basis, find a responsible partner because there are things the government used to do that they have intentionally not done. And that's just devastatingly sad to me. Again, I do not speak on behalf of any university or federal agencies.
Well, and obviously everything was good because no one cut off the microphone. I'm teasing, Jack. Anyone else?
You don't know what the live stream just did.
Just going to kind of add to what Dr. G was saying about establishing a relationship with the local health system. A plug for Child Life Specialist is that, so following a cancer diagnosis, a Child Life Specialist could come into the classroom and teach the other students in the classroom, if it's something that the child wanted, sort of what's happening, like why they're losing their hair, why they can't be in class all of the time, what they can expect moving forward when they're not in class, like the ways that the child might still want to be included even if they're not physically present. There's so many like really big layered conversations around cancer that can happen that can be so therapeutic, not just for the child, but for their whole classroom. And I think the same is true for really any diagnosis. And Child Life Specialists I know are trained to go into schools as well. So maybe even kind of going back to your other question about asthma, like sort of a asthma education campaign, bringing the science into it, but then also like teaching in a developmentally appropriate way, like everybody has an inhaler, like let's normalize this. Like I think there could be a role with sort of having that like ongoing back and forth, and you learn what the hospital has, how they teach their patients about asthma and what kinds of language they use. So then you can kind of build on that foundation as well.
So go on. This is amazing, and we'll give you a big resource in a second. But like we shows you where my mind is going. But in 2019 in Baltimore City, we launched a cystic fibrosis campaign at some of the schools, teaching them about lung health and so forth. The reason for it is cystic fibrosis. Sometimes you may just think it's a white person's disease, but there were plenty of diverse students with it. And they felt stigmatized because they would show up to the schools wearing face masks. They're like, what's going on? So we went in and just taught what the school can do to accept them. This is before the pandemic. It's 2019. How to accept them, and also why they all should be vaccinated to help them. Right? So we had these conversations, and the kids loved it. We had great scores. It was the pediatric CF group that helped us with it. It was amazing, very well received. If you want resources, because we are in DC, let's connect, right? From heat core to medicine for the greater good, we do all this, right? Our CHW teachers, we've trained, we've created them, and we finance them. So happy to have these conversations with you guys as well.
Thank you all.
Yeah, of course.
You said you had a question.
Oh, I did. Are there more questions? Oh, let me find my one line. Yes, over here. Well, yes, go.
Keep looking up the online one at the same time.
Well, yeah, no, because some of them are being answered, or I'm just getting emails saying, oh, great response. I'm getting fan emails. This is great.
Sorry I came late, so you may have discussed this, but I just had a question about geriatric medicine. I asked, my general practitioner whether someone, older should switch to a geriatric specialist. And she said that unless you have an ongoing, serious issue, in a sense, don't be selfish, let somebody who does have a serious elderly geriatric issue take, because there's so limited number. And I just wonder, is that really the case? And what is your advice on that?
So there are not a whole lot of geriatricians, and so I think that the point is understood that the availability of the specialty is, there are not that many of us. So, but that's not to say that would necessarily should inform your decision if you were to seek care from a geriatrician or not. I know at our practice in Baltimore, we're accepting patients, so I don't think the doors are like, oh, we don't have space for more patients. The panels are not closed. So I think in thinking and making a decision about this, I think one has to understand for themselves, first, are they feeling like they're being heard by their primary care doctor? And I think this goes for anybody, but particularly for an older person, do they feel like they are being heard by the practitioner that they're currently seeing? Do they have adequate time? Typically, our follow-up visits are not like the 15-minute model that many practices are. We have 30 minutes for follow-up visits and an hour for new patients. That's kind of how things are impaneled. And then in addition to having more time, we are trained in the physiology, the pharmacology, of people who are getting older, and things do change as older people do experience. And so we are particularly good at that, understanding that, as well as also understanding and helping people navigate the resources that they may need as they get older, as well as navigating systems as you get older. There's a variety of things that older people may be eligible for in terms of care models, to get additional supports. And so we're very good at working with the individuals, and then also working with families. So most kids don't show up to the doctors by themselves, right? There's parallels in terms of some of the things that are happening for people who are getting older that I think more families are becoming involved with. And so we are expert in working with families as well. So,
but if you're in good health without chronic disease, is it still okay to stay with your family practitioner, general, practitioner? I mean, would she not necessarily know things that you would know, as you were saying, as an expertise in gerontology?
So we do get extra training, and I know that general internists that provide great care for older people, but I also know general internists who manage a lot and do a lot that we would say, particularly in geriatrics, some of those things that you're doing may cause more harm than good. And so there's a balance. I don't know what the specific situation that you're in, but I would just generally say there's potentially an opportunity to go and meet a geriatrician, establish your first visit to kind of, interview and clarify, and for yourself compare if you think that would be a good transition. I do think that for someone who is healthy, there is this idea that you're going to have many more years, and I think that there's a value in transitioning care to someone who can help meet your needs that you may have 10 years from now versus, you start having troubles and then you're trying to switch to someone who, and so that's what I would say. So I think many of us think that our sweet spot is potentially around people who are in their 70s, not just when you turn 65, start seeing the geriatrician, but many of the people we see are in their late 70s, in the 80s and 90s. So yeah, I'm happy to talk more with you as an individual about things, but.
I want to add one component, and I'm going to read the online or the email. Or did you have a question? Oh, okay. I saw a hand. I'm like the teacher in me. So especially for the schools, you may think such conversations like, well, how does that impact kids? Schools have the ability to bring adults and families together, and it doesn't have to be kid specific, right? Our CHW teacher held a whole conversation about diabetes management for families, right? Your school holds so much power, and for right now might be the only trusted source for many communities where they're seeking health information. So just recognize that. So maybe there is a geriatric talk for the grandparents in the school systems, right? So just recognize the talks don't always have to be student-centric. At a time like this, you may be seen as the only trusted resource that people want to show up to. Dr. Johnson, this is a question for you, Marcy. Oh, hold on, let me open it back up. There are many mental health issues our students face. When should they see a mental health specialist?
So that's a great question. And I don't know that there's necessarily one right answer to that. I would say if you're noticing, the thing that we're looking for is we're looking at changes in behavior, changes in feelings, changes in thoughts, and how those changes might be affecting the student in their day-to-day life. So wellness, right, and well-being is not necessarily the opposite of illness or ill-being. They're kind of two separate dimensions. We're all going to have stress in our life. We're all going to have days where we feel low. We're all going to have days where we're worried about things or we're feeling unmotivated. That's okay. We can still be well even when we experience those. What we're looking for is sort of, is this stress, is this low mood, is this worry getting in the way of the student being able to do the things that matter to them and that are important to them and are important to their development? And when that becomes, or you're concerned that it's moving in that direction and that becomes apparent, that's really when you do need to refer for intervention. So I would say, right, we're looking kind of more for patterns than for single symptoms, let's say, or single behaviors. We're looking for patterns over time. Of course, if there's any concern about safety, meaning harm to self or harm to others, that's a situation in which immediate intervention is required. So if you're ever concerned that a student might be thinking of killing themselves or killing someone else, calling 911, calling 988, that is a medical emergency and a psychological emergency that needs to be intervened on immediately. If this is more of sort of over time changes in mood that is non-urgent, we're looking for patterns over time, and the threshold is kind of when these things, or if you feel like these things are starting to interfere with the person's ability to engage in their life with meaning and purpose, we should intervene.
Okay, but how is that different from adolescence?
It's tricky.
I took 3 teenagers through what seemed like that experience.
Yeah, no, I mean, it's tricky because, right, there are changes in mood, changes in behavior, changes in feeling that are completely developmentally appropriate. And so I think, right, that key piece of, is this getting in the way of you living a meaningful life, right? And is this getting in the way of you doing the things that matter, right? So it's one thing if your teenager's in a bad mood or low mood, right? But is still going to school, is still doing the activities they like to do, is still hanging out with friends, that's probably okay. If your teenager is is having low mood for an extended period of time, stops going to school, stops doing the activities they used to enjoy, stops hanging out with friends, that's an area of concern. So even though, yes, all of these things, right, there's a version of many of these things that are developmentally appropriate, we can make a distinction between when this is sort of within a normal range versus when we might be more concerned about it.
So we're going to wrap up. There's no more questions online. You guys are getting a lot of emails, well, sent to me, but I can't forward them. But they're liking what you guys are saying. So everyone, 30 seconds or less, closing thoughts. You turn on Jack's microphone again. I'm teasing. Jack, you get to kick things off with closing thoughts.
What you guys are doing is amazing, and just thank you.
Spoken like a true intensivist.
Yeah, no, I think some of the things that we've said and that I've even learned or clarified in my own mind today, I think, meeting people where they are, I think identifying resources where we are in terms of in the community that you're in can be really important. And then lastly, I would say, I think continuing to try to support people as best as you can, understanding that, things take time to improve, and that, there's, efforts to help people through whatever experiences, trauma or not, is something that, it takes time. And so I think that things that occur, where people are experiencing difficulties, we have to just take time with them in that experience. So that's where I'm.
Spoken like a true geriatrician. Excellent. Marcy.
Yes, to everything that's been said. I'll just add that, I think it's important to remember that how we respond to people, how we interact with people, that matters. And so being mindful of our own biases, being mindful of the language that we use, both in our practices, professionally, in our personal lives, across the board, it matters. We are all sort of in relation with one another. And so understanding sort of what you're bringing to the table, what you're giving, and also what you're able to receive, I think is so important in the context of trauma, in the context of schools, in the context of being a human being. So thank you all for being here.
Perfect. And Molly, last word. Make it the best.
I would say, one thing to take away is I hope that we will all think more of how we can strengthen our relationships between schools and health systems. I feel like this comes up in so many conversations I'm a part of, and it just feels so important. So thank you all for doing the work that you do. And I guess a takeaway I would say about trauma-informed care is remember that it is universal and it's relational. So it is sort of how we show up moment to moment across time. And if you don't feel that your, approach is perfect the first time, that's okay, because you have, again, these moments across time to build rapport and strengthen relationships through a trauma-informed lens with your students. So extend grace to yourselves as well. And thank you all for doing what you do.
Perfect. Round of applause. And now we have lunch. Perfect. So we'll break for lunch, and then 1 o'clock we'll reconvene for anyone for some hands-on activities, and also Narcan giveaways as well. So thank you guys so much. Do you want to say anything, Megan? No. Perfect.
I feel like Narcan giveaways, 2026 schooling in a nutshell.
Are you with Hopkins?
Yeah.
Okay.
Yeah, and I'm like, I want to so